Hi, and welcome to the Vet Dental Show. This is our 100th episode. So we've been doing these for almost 2 years, and we're going to do something a little bit different today. I have 5 things that you don't want to hear in your dental suite. So let's get to the first thing that we don't want to hear. This procedure is taking way too long. You've been with this patient for an hour and a half. So let's break that down a little bit. Maybe that's a common thing in your practice that you hear that. And if you're in an hour and a half and you're doing a dental procedure, you're probably doing it correctly in that many of the procedures that we do in our patients, especially in our perio patients that are 20 pounds or less, those patients require quite a bit of time to complete in the proper manner and in an efficient manner. The more training you have, the more practice you have, the more efficiency, and the quicker that procedure can be completed. However, when we look at an hour and a half for a patient that is, let's say, 6 years of age or older and 20 pounds or less, it may require multiple surgical extractions. And as you guys know, you listen to this podcast and you see what we put out on a continual basis, and you've been in our courses, you know that an hour and a half is not a lot of time to be in that procedure. Generally, we have to look at how long the average patient takes you at your training level to complete, and whether that's a stage procedure where you do part of the procedure initially and then you get the patient back and you complete the rest of it. If it takes you past a certain amount of time, that's perfectly fine as well. And we'll get into that at some point. But in order to schedule properly, if we have that many hours that we expect to at least be in to start the procedure on a patient that falls into that category, and anything over that is not acceptable based on the practice, we may need to consider that an hour and a half is probably on the low side of the time frame when it comes to scheduling an individual procedure. We also have to think about the transition between patients. So, hour and a half, if you are in a management position or you're in a position in the hospital to make decisions based on dentistry and you want quality dentistry done properly, it may take 3 hours or more to do a periodontal procedure properly, where we're doing surgical extractions using mucoperiosteal flaps and creating an environment when we close that up that patient has absolutely no or very minimal inflammation and that we've eliminated any sepsis going forward. So in order to provide that, we definitely cannot be in there for short periods of time and be able to do things properly. So that is definitely something we don't like to hear, that the procedure is taking too long. You've been in there for an hour and a half. So let's transition to the next thing that we don't want to hear. Go ahead and pull those teeth. The owners will be fine with it. And that is a statement that will get you in trouble many, many times. And I say that because I hear that in conversations with patients that have been referred to me for periodontal disease mainly, where the owner had made the appointment for the patient to have a cleaning, and communication wasn't there at the beginning for one reason or another. There may be multiple reasons for that. Um, just to back up a little bit, we should have permission to call the owner during the procedure. If we don't have that, we would not recommend doing the procedure. And pet owners now, pet parents are where, especially if they're in a situation where they're going to get really quality care and it's going to take a long time and anesthesia is involved, they want to be kept up to date. So that used to be an issue where we couldn't reach owners. We had pagers at one time, believe it or not, where we'd have to page the owner and then they'd get on the phone somewhere and call us back. That obviously is not even an issue now. And so it shouldn't be an issue with your dentistry service the way it's set up and the communication that you have with the pet parent before the procedure starts. There will be extractions, and in those cases, we want to let you know what's involved. We may find other things that we need to talk to you about. So when we start the procedure, we'll give you a call, let you know. As soon as we get the radiographs and we have a good idea about what we're going to be doing as far as treatment goes, and obviously in periodontal disease, a lot of that treatment is going to be extractions. So that statement should never enter into the conversation in the dental operatory. If it does, it's setting you up for a very disgruntled owner who is expecting cleaning, and then when they pick the patient up or after the patient has completed, the procedure's been completed, the owner's informed and their response is, I didn't give you permission to do that. And that's perfectly understandable. So knowing it from the referral standpoint, where I've seen pet owners time and time again come in for additional evaluation and periodontal care and cleaning and prophylaxis, and indeed, that's their number one complaint. And many times they are not visiting that practice anymore because that episode happened. So it's a good way to lose clients, especially. So keep that in mind. Go ahead and extract those teeth. The pet parent won't care. That's not something we want to be saying in our practice. So let's look at the next thing that we don't want to hear. That area is fine. There's no need to do radiographs. And how many times in a busy practice does that come up? We need to really ask ourselves what the implications are of that. And there's a lot of studies that have been done, and one that's one of the older studies that's been a standby for quite some time was done at UC Davis with Dr. Verstrada and others, and they looked at patients that had absolutely no pathology, and they radiographed those areas and full mouth, obviously. And the areas where no pathology was present visibly had, in dogs, 28.7% pathology when radiography was performed in that patient in the areas that look normal. And in cats, it was 41%, almost 42%. So if we're not radiographing everything on every patient, we're doing that patient a severe disjustice. We're also doing the practice an injustice from a revenue standpoint, and most of all, the outcome of the patients that don't receive radiographs and have significant pathology is likely and can be not just discomfort, but could be serious pathology or significant pain. So it behooves us to never, ever bring that up in the dental operatory, that there's no need for dental radiographs in that area, because it is a very important thing to take full mouth radiographs and to be able to catch those things that we know that we're going to see that add to that problem in the number one thing that we don't want to see in the dental operatory, and that is that the procedure is taking too long. So definitely eliminate that. We want to have a complete evaluation of every patient that comes in and be able to perform what we need to perform to allow that patient to have the best outcome possible. And if it's got pathology there and we're missing it, then it's our fault. And we may or may not know that going forward. The patient suffers silently. And so we have to take a look at our practices if we hear that in our dental suite. Another thing that we definitely do not want to hear in our dental operatory is hurry up and clean this one. We've got 3 more before lunch. So kind of back to that original statement about an hour and a half in a procedure is not that long. If we are scheduling accordingly, we should have nowhere near 3 patients for dentistry in a morning, unless they are several month rechecks for minor perio things that we've done that we're following up on. For the most part, that same scenario, 20 pounds or less, it doesn't have to be 20 pounds or less. It could be more than 20 pounds, but that's the most characteristic that we see. That patient is going to, from a predictability standpoint, at least be an hour and a half, but we need to maybe set our time frame a little differently even for that patient. So 3 patients in the morning and hurrying to finish does none of them any good. It would behoove us to look at our protocols, find the person in the practice that is the best and the most efficient. And this is a long-term resolution of this problem. And it's also the best for the patient. It's also best for the clinic. Find that person who's the best at dentistry, the quickest at dentistry, that enjoys dentistry. Put the resources of the practice to training that person or providing additional training ongoing for that person. And then making sure that we've got a system set up where that person is doing most of the dentistry in that practice, especially the cases that are perio cases in those small breed dogs. Even then, at a level that that person can achieve with targeted training and ongoing study, 2.5 to 3.5 hours for a periodontal case in a small breed dog is not unheard of. So when you look at that and you take that into consideration, even at a specialty level, a lot of my colleagues and myself included in certain circumstances don't do more than 2 or 3 perio cases in a day because it takes a while to do those. So if you're in general practice and you've got a pretty good handle on surgical extractions and you consider yourself pretty good, you still got a lot of room to go as far as training goes, but that instance, and certainly that's a subjective assessment, you're pretty good. You're comfortable. You're not frustrated. Often, I'm still frustrated every day, but you're not frustrated often in the procedures. You know that you've got enough confidence to get you through it and make it so that that patient outcome is really good. I would schedule no more than 3 procedures per day maximum. And when you think about it, if each procedure takes 2 hours, depending on your transition phase between those patients, getting that next patient up and induced after that patient is off the table and recovered could be 30 minutes, 40 minutes, an hour, depending on your practice. So taking that into consideration and just saying 30 minutes for a real ideal scenario between patients, then 2.5 hours, that's 3 hours for one patient before you get to the next patient, in addition to the 30 minutes it took that patient to get ready. So 8 hour day makes sense that you would be pushing to get 3 patients in that take 2.5 hours each with a 30-minute transition phase. So keep that in mind, use those parameters. And if you are hearing this, and this your practice, if you're hearing this, this is not uncommon at all. Unfortunately, this is probably still the discussion, probably still the mindset of many practices is we do a certain number of dentistry cases, and that's what we're focused on. So that needs to change on doing each patient better. And automatically, what you find is that that person that's doing the dentistry gets better and better and better because they're doing it correctly. They don't have the stress of somebody looking down and over their shoulder to make sure that they're getting things done in what the practice feels is a quick and efficient manner. And so they're at ease, they enjoy doing dentistry a lot more, and they know the end result is the patient is going to be the ultimate one to benefit from that whole situation. So hurry up, you got 3 patients before lunch. That should never happen again, and if it does, you need to really consider making inroads to talking to the powers that be and getting that changed. And that's not an easy task. So anything we can do to help with that, let us know. Put your comments in and down below where you are listening to, or maybe you're watching this on YouTube. Put your comments down and let us know your situation, and let's start a conversation around that. So let's look at the next and final thing that we hear in the dental operatory that we shouldn't be hearing, and that is we need to get started. We can do the nerve blocks after the procedure. And again, all of this comes back to attempting to rush through procedures which should be valued and respected surgical procedures that involve microsurgery. Essentially, we're working in millimeters, and we're working many times on very small patients, and we're working in the mouth where the airway is. So a lot of things to consider in the time involved with that. But nerve blocks are essential for multiple reasons. And the biggest reason is that, in my mind, is the ability to keep that patient super light under anesthesia. And if you've heard us speak about this topic before, you know we attempt to keep patients at a level where they actually have a palpebral reflex. They have some degree of jaw tone, not enough to bite down on the sensor and destroy the sensor, but they have enough jaw tone to be consistent with a palpebral reflex. And many times when we turn that patient to do the other side, we find that they become partially ambulatory. They start to retroflex their neck. They may move their limbs just because we're disrupting them. Whereas what we've done before with the nerve blocks doesn't matter, because we can do mandibulectomies, maxillectomies, palate surgery, multiple extractions that induce a lot of surgical pain. And because we've got that total C fiber blockade to that whole quadrant, the patient doesn't feel anything. But when we turn them over, just that manipulation of their positioning excites them cerebrally, and so we get that activity. So that's a good level to be, and that's what our nerve blocks allow us to do. So if we don't place those until after the procedure, there's no benefit intraoperatively, which is, in my opinion, again, the biggest although the second reason comes in the close second, but the biggest reason why we should be using nerve blocks. The other reason is the profound effect we get on post-op analgesia. That's tremendously helpful, especially now where we've got agents that have liposome encapsulation around bupivacaine molecules that allow that agent to be in place and effective for up to 3 days. And for those of you who are familiar with Nocita, we have gone exclusively to that and have for quite some time in our specialty practice and in our dentistry only practice in Atlanta. So we teach this, we teach incorporating that into your practice. And just a quick mention of how to do that, and something that I would look at doing as an action step next week is to call Elanco, call your representative. They will come in and they'll demonstrate the procedures for you. They'll educate you on using that agent, which is, again, bupivacaine, but it is a long-acting bupivacaine. And if you're doing a lot of dentistry and or you're doing other orthopedic procedures, then off-label use of Nocita for dentistry is becoming a pretty mainstream thing. So please consider that as an action step to get with your Elanco rep, have them at least show you what the benefits are to this. It has really altered the pain management for our patients in both dogs and cats in our practice and in our dentistry only general practice. So waiting until after the procedure to do nerve blocks is not the way to go. It's definitely detrimental to the patient. It's risky from an anesthesia standpoint, and hopefully you will never hear that again in your dental operatory. So I hope you've enjoyed those 5 things that you never want to hear in your dental operatory and an explanation on those. Comment wherever you're listening to this or watching this if you're on YouTube, and let us hear what your thoughts are. Also put in questions that you may have about other things that we can address in other podcasts, and we'll start doing that more and more as we go through. So enjoy the week. Thanks for joining us on this 100th episode, and we'll hopefully see you for many, many more. Take care.